This has been a great discussion. Why don't we shift now to talk about the last abstract, and this is the one from the ASH annual meeting that we're at right now. So maybe, Jamie, tell me a little bit about your thoughts on this one. So as a reminder, this is the kind of longer-term commands trial follow-up, specifically looking at response durations and response rates and what we're seeing as those data mature with luspatercept versus EPO.
Right. So what I found particularly interesting about this trial, it really did a bit of a subgroup analysis, and I think there's been, some controversy over the subgroup analysis and, RS negative patients, RS positive patients on commands. But really, when we looked across all the subgroups, kind of regardless of EPO level at baseline, regardless of ring sideroblast status, and again, this is not, statistically powered to detect differences, but numerically, we saw that in terms of this longer duration of transfusion independence, numerically, pretty much across every subgroup, patients treated with luspatercept, a higher percentage of those individuals were having these long-term responses. As you mentioned earlier, Andrew, there were some in the ESA and the apotin alpha group as well. But I think looking, again, numerically across these subgroups, it was really a numerically higher number of luspatercept treated patients who tended to have these long duration responses.
I think the endpoint of 1 year or more of transfusion independence, it was around 45% with luspatercept and around 28%, something like that with EPO. So yeah, there's definitely some, and there's just more with the newer agent. But really, we need all of the agents for these patients who are going to live longer than the median duration of response, unfortunately. Any other things you'd add about that particular abstract, Andrew?
No, I think my big surprise is that you really can have some profoundly long responses. I think a year and a half without needing a transfusion is really normal life. That is getting someone back to a meaningful period, and how can we use these long-term metrics to say, well, if we want to optimize a whole population of people, what should we be aiming for? How do we make that our goal? Right? And when we think about new agents entering this space, can we look at combinations, for instance, where maybe we were trying to get transfusion independence for 8 weeks, but how can we say, well, can we add things perhaps? Can we use these long-term goals as combination endpoints? Something where that would really be a meaningful change in your living with this disease.
Well, I think to your point, when we're taking a patient who's requiring, transfusions at baseline, we get them a year and a half or more of transfusion independence, does that then become a disease-modifying therapy potentially? We don't really, I think, even completely understand all the toxicity associated with transfusions. I mean, I think you really nicely outlined, iron overload and alloimmunization, but certainly there can be other detrimental side effects of transfusion as well. And so I think, is this then becoming a truly changing the course of the disease and perhaps even improving overall survival in these individuals? What I would love to see are, what biomarkers can allow us to identify these patients that are going to have, these prolonged responses to a drug like luspatercept versus, another agent like imetelstat, right? That's the same type of trial where some of these patients just, they are really almost super responders. We're seeing years of transfusion independence. But who are those patients, I mean, 40% of patients respond. Who are the super responders? How do we identify those patients and, really individualize therapy selection?
It's an exciting time for MDS.